So this is a case of a 75-year-old male who underwent thulium vapor resection in another province. He was referred to me because of hematuria and retention again. So the prostate is quite large again. So you should see in the initial cystoscopy, quite inflamed. If I remember correctly, it's around 90 cc again. So yeah, so obviously there's a lot of bleeding here, and right now I'm trying to assess on how I will approach the case. So yeah, so normally vapor resection is not really that quite effective, especially for large prostates, and obviously there would be a recurrence. And like for example, this case, it recurred after 1 year doing the procedure. Maybe it's because of the incomplete resection, or maybe something else. So yeah, so I still begin with a similar approach as to what I do in thulium laser enucleation of prostate. I will begin again with like an omega incision at the both sides of the barrel, connecting it to the other side. So it's really nice how the holmium laser would be able to dissect quickly towards the plane. So this part, I'm doing an early apical release, similar, almost similar to that of Professor Sancha, and trying to release. And of course, the main advantage of this one, most of us already know that it will help in the early recovery of urinary continence. So after doing a deeper incision, I put in, I nudge the lateral lobe and then continue using the laser. Now I'm already at the anterior part of the prostate. You can see the nodules here, and it's very nice how the prostate moves away from the capsule whenever you fire the laser from this one. So yeah, so here releasing the mucosa again, the anterior part. So yeah, this prostate is quite what I call usually a juicy prostate. A lot of blood vessels, a lot of bleeding going on, but it can be controlled properly by the laser, and we can see how it affects the tissue. It turns the tissue white. But sometimes when you put in the laser longer on a certain side, it turns a little bit brown. So I think that's some sort of carbonization as well, but not as dark as that of the thulium laser. So now I'm releasing the anterior part already. I have released the anterior part, and now I'm trying to do my incision going down towards the equator, controlling the bleeder as we go along. And you can see a lot of nodules already. I think it's more of like inflammatory nodules coming from the previous surgery as well. So here there's still a very nice plane between the capsule and the prostate. So it's very nice. It's the laser would be able to like separate the gland from the capsule. And I like how the holmium turns the tissue to white also, at the same time controlling the bleeders as long as I pass through it with the laser. So similarly, I still use a little bit of a mechanical dissection to release the prostate from the capsule. A little bit of like the force or mechanical force that will help the prostate move away from the capsule. So now I moved to the other side, to the right side of the patient. So the incision, firing the laser as much as possible near the prostate, not towards the capsule, so I'll be able to, so there would be no like we will not be able to like do any perforation or make any perforation during the procedure. So yeah, so controlling the bleeders along the way. It's very nice how the laser really controls it properly. So this one I'm using a Cyberhole 150 watts, but my setting is 2 joules and 50 hertz, and I turn on the virtual basket, and the virtual basket actually helps based on the publications. The virtual basket actually helps in control of bleeder and makes the procedure actually faster. So again, yeah, the speed of the procedure is mainly, I guess, it's not really about the laser. It's more of the technique. It relies upon the experience of the surgeon, and of course the size of the prostate as well. So yeah, so we already have released the anterior part of the right lateral lobe, and now again incising towards the lower part of the bladder neck. So incising it towards until it reaches the floor of the bladder. So this one is, I think, one of the things that we can consider if we do this incision to decrease the probability of bladder neck fractures. I've seen some. I haven't seen any publication that would address this one. Maybe later on, this is something that we can think of. So far, with regards to bladder neck fractures, I'm only able to see, like, for the almost 2,000 cases that we have done, I've seen like around 3 or 5 cases, and pretty much it's I often see it in cases with a very small prostate. So I think it's related to that. It's related to that. But also, again, if it's large enough and we are able to remove put down the bladder neck, the invaded neck, and we are able to incise it towards the equator, I think it would help in decreasing the chances of bladder neck contraction. You can see here that I also still try to remove the nodules along the way as long as I can identify it. Try to remove as much as I can the tissue along with the nodules that's attached very closely to the capsule. But we have to be very, very careful when it comes to this one, since we are making the capsule very thin, and the chances for perforation is higher. So if there are if we encounter perforation, as long as it's not that big, I think it's okay. We can just continue with the procedure. We don't need to stop the process. The whole thing will not change. Same amount of time in putting in the catheter. However, it's different when you find a larger perforation. Of course, you have to. For me, I would increase the time for catheterization, and make sure I use a catheter guide to put in the catheter, so there will be no false passage, so a different or get through the perforation and cause a lot more trouble for the patient again. So yeah, again, the part here is quite adherent. I think it's because of the inflammation that has happened, since the patient already had a previous surgery, and the patient had an active bleeding and obstruction. The obstruction was not really because of fats, it's mainly because of the regrowth of the tissue. Uh, and yeah, so okay. So again, when you fire the laser, it's better if you fire near the prostate, not the capsule. So that would help you actually identify the plane between the capsule and the gland faster. So it also helps you dissect the tissue away from the capsule faster. So yeah. So right now we're trying to release one side and the posterior as well, posterior part of the prostate away from the capsule. So we're done in the anterior and most of the lateral sides. So and if you get lost, especially for large prostates, if you get lost, it's always going to the more familiar part. So go to the normal anatomy first. Try to go to a more familiar area where you can really identify the capsule and the gland, and then start dissecting again from there. So the chances for you to have a problem would be less. And you can see here, I think the virtual basket is really helping because these are really large vessels. Because of the inflammation, you will be able to notice the vessels that are large, and the virtual basket is really helping in controlling the bleeding. So yeah, so it's beautifully getting the plane between the capsule and the prostate gland. And here you can see that the prostate is quite something like inserting within the bladder neck. So you usually encounter these kinds of prostate if it's really large and nodular. So it goes underneath, even underneath the bladder neck. So be careful to not really keep on using the laser, especially on this part, because you might perforate or go subtrigonal in these areas. So a little bit of blunt dissection would help in helping you dissect the gland away from the prostate. So I think it's pretty much helpful. So right now we're already at the bladder neck, the posterior part, and we are able to release one side of the prostate already. So yeah. So a little bit of lifting of the prostate and pushing it towards the bladder neck, and then also controlling the bleeders and cutting the prostate, the bladder neck, using the laser. Just slowly pushing it towards the bladder. So I think this is something that we can do. Most of us would be really afraid to dissect the posterior part. Normally I would really suggest, when you do this, instead of just pushing the prostate forward, the push should be going up towards the opening of the bladder. So we don't really just push it forward. It's more of like a lifting the prostate towards the bladder neck, not pushing it towards the posterior part of the bladder neck. So right now we notice that we are leaving some parts of the prostate on one side, but yeah, we're going to try to address that in a while. So Right now, the main goal is to release most of the tissue. So yeah, so we're able to identify the last few attachment of the prostate, the posterior attachment of the prostate. So it's very nice how the virtual basket helps in controlling the bleeders, the blood vessels. So you can actually see what you are trying to dissect, and it's not bleeding at all as well. So it does help. It's very nice, very beautiful. So we're just releasing the last few parts of the prostate. So yeah. Let's try to meet the attachment, and yeah, there you go. So yeah, so we are able to identify the last few attachments that we were not able to remove earlier because of the adhesions. We were not able to identify it properly, and yeah, so now we are able to push all the prostate inside the bladder. So it's just similar to that of like an N block, not totally N blocks, because I usually incise at the 12 o'clock region. That's the technique that I'm using. I developed my own technique that I'm incising 12 o'clock, and I always follow this technique, and I think it's more feasible to be doing this one, and it's really applicable to any form of end firing lasers. I think I've tried different lasers. You've seen in my previous videos, I've been doing like even low power holmium, thulium YAG, TFL. So right now I'm just trying to make the prostatic fossa white, control the bleeders, so I'll be able to visualize everything when I'm going to do the morcellation. So the key in doing very safe and efficient morcellation for me would be, number one is some well-controlled prostatic fossa. This in turn will let you visualize the whole bladder, the bladder neck, also the prostate that you are trying to morcellate. So again, yeah, I think this part is the one that we're gonna change into the morcelloscope already, and then we're gonna be using a morcellator to remove the prostatic tissue, the gland that we have inoculated. And one of the tips that I can say is actually like what I said, control the bleeder properly. Make sure that there's no, you can visualize the whole thing. Like this one, you can see the bladder, you can see which one is the bladder, which one is the prostate tissue. And if you find the prostate a little bit harder, like somewhat more firm compared to the usual ones, you try to lower the rotatory speed of your morcellator, and then well, maximize the suction, so that there'll be more suction. So this one, we're using the cyber blade. We are able to do this with a similar. I know a lot of people would not like and call this as just a backup morcellator, but so far it's pretty good. It's actually doing its job pretty well. So yeah, I hope I was able to share some insights here. Thank you again for watching. I'll try to post some more videos soon, and hopefully I help you guys in learning more about enucleation. Yeah. Thank you.